Thank you very much for inviting me to present at your New Jersey ACEP Scientific Assembly. I wish I could be with you there in person, but of course, it's COVID times. The title of my talk is Evidence-Based Medicine, What It Is and What It Isn't. And I run the Skeptic's Guide to Emergency Medicine website. It's a knowledge translation that involves a blog and a podcast. Each week I do a structured critical appraisal of a recent publication, trying to cut that knowledge translation window down from over 10 years to less than 1 year, using the power of social media. But I'm not here today to talk about the SGEM. I'm here to talk about one of my favorite topics, evidence-based medicine. So I'm going to tell you that this talk was inspired by an article from 1996. Yes, I realize some of you residents may not have been born yet. That's 24 years ago. But it's one of my favorite articles of all time. And I would encourage you to go back and read the paper. In fact, I would encourage you to be skeptical always and go back and read the primary literature for yourself. But this article was in the BMJ 1996 by Sackett et al., and it was titled Evidence-Based Medicine, What It Is and What It Isn't. So, there are 3 basic messages I want to leave you with after this talk, and I'm going to tell you right up front what they are. So here are the 3 things that I want you to take away from the talk today. The first thing is evidence-based medicine. It rocks. I mean, once you get a taste of practicing evidence-based medicine, it's hard to ever go back to any other form of practice of medicine. And we'll go through 5 other forms of medicine that could be practiced, and I'll explain why I think evidence-based medicine is the best of the bunch. The second thing that I want you to remember is that when anyone asks you a question, the EBM answer is, it all depends. There's going to be a question-answer period at the end of this talk, and I may say to you, it all depends, because everything takes place in a context. It's on a spectrum. Rarely do we see these black and white issues where it's dichotomized. And so I learned this from my EBM mentor, Dr. Andrew Worster. And he's out of McMaster University, the home of evidence-based medicine. And he started a knowledge translation project called Best Evidence in Emergency Medicine, or the BEAM group. And he brought me on board about 15 years ago. The third thing I want you to remember is to be skeptical, even of me. It doesn't mean you're closed-minded to be a skeptic. Rather, you should be very open-minded, just not so open that your brain falls out. The time to believe something is when you have convincing evidence. And until such point, it's, I don't know. So those are the 3 take-home messages. EBM rocks. The answer is, it all depends, and be skeptical. So here's what we're going to talk about today, and it's my favorite number of items, 5. So we're going to define evidence-based medicine. We're going to use a Venn diagram to do that. Then I'm going to talk about the hierarchy of evidence-based medicine. And this is specifically talking about the quality of the literature or the quality of the evidence, not the other parts of evidence-based medicine, but specifically on the literature. And then we're going to go diddle-doo, diddle-doo, diddle-doo. You see how New Jersey ACEP spared no expense on this virtual meeting? Yes, those sound effects were time travel. We're going to look at some historical aspects of evidence-based medicine. And this is Dr. Franz Mesmer. I know you know who he is, but you might have to hear the story to remind you of this famous German physician. So a little historical stuff. And then we're going to take a 5-step process on how to do a structured critical review. So there's going to be some practical aspects to this lecture as well. And then finally, after we go through that 5-step process for critical appraisal, I'm going to put forth some arguments about what are the limitations of evidence-based medicine. All right, so those are the 5 things we're going to go through today. I always think it's good to start a conversation with a definition that you can agree on. And so since I've been talking about evidence-based medicine already, or EBM, I'm going to tell you the definition that I use. And guess what? It came out of that Dr. Sackett paper from 24 years ago in the BMJ, 1996. Dr. Sackett defined EBM as the conscientious explicit, judicious use of the current best evidence in making decisions about the care of individual patients. Now, each of those words is very important, so I've picked them out. We need to try to be conscientious about our decisions. We also need to be explicit in what we're doing. Be precise about it. What are we doing? And then, of course, use our judgment. And hopefully it's good clinical judgment. And then we need to look for the best evidence, not just the evidence that confirms our bias, but the evidence, and the best evidence should be used. Now, I added the word shared decision to Dr. Sackett's definition, and I think we should share our decisions with our patients and include them in the decisions. Find out what they value and what their preferences are. And it's about individual patients. We care for individuals. We have an N of 1. We usually are not treating a population, unless, of course, you're in public health, and that's happening quite a bit right now. But we usually treat patients one at a time. And so shared decisions about the care of individual patients. So that's the definition of evidence-based medicine that I'm going to be using for the rest of this talk. Now, I've got a visual representation as a Venn diagram. And in this Venn diagram is the representation of that definition of evidence-based medicine. Now, down there in the blue, you can see the literature. And the literature should inform our care. It should guide our care. But it shouldn't dictate our care. There's very few things in medicine that are, thou shalt do this and thou shalt not do that. So the literature is the foundation that informs our care, but it doesn't dictate our care. You as a clinician still need to use your good clinical judgment and apply it to the patient that's in front of you. And that patient has their own values and preferences. And what are they? How do you know what they are? You have to ask the patient. Don't assume. Patients can have different values than the clinicians. They can prefer different treatments that may not agree with your values and your preferences. And so engage with them. I always say we're the experts at medicine, but the patient is an expert at them. And so ask them. Don't assume. That's evidence-based medicine. And so you'll see it here represented in another Venn diagram, but more with pictures. And the most frequent mistake I see people make when talking about evidence-based medicine is that they think it's just about that stack of scientific literature there on the bottom. And that's not true. Now, you need to know the relevant scientific information to inform your practice, of course, but you still are a clinician. There still is that art. And sometimes you'll have lots and lots of experience. It's like, yeah, I've seen 100 of those. Other times you may not have very much experience at all. Same thing with the literature. Sometimes there may not be great literature on the question that you have. There might be only case reports, observational trials, expert opinion. But sometimes there might be really definitive systematic reviews and meta-analyses that are really high quality that we can rely on. So those circles are all equal because they're equal importance, but what they contribute may differ in size depending on the situation. And then, of course, it starts with patient care and it ends with patient care. And we all want patients to get the best care based on the best evidence. So those three components make up evidence-based medicine. There's the literature as the foundation, informing our care, guiding our care, and then using our good clinical judgment and engaging with the patients about their values and preferences. Now, I did say that there's a hierarchy to evidence because I was talking about you've got to find the best evidence to inform our patient care. And this is usually described as a pyramid, but I like this picture better. A stack of flawed asymmetrical rocks, because there is no perfect study. Every study will have some limitations. Every study will have threats to its validity. Every study could have problems with external validity. And so they're not all perfect. But traditionally, the lowest form of evidence on this evidence-based medicine hierarchy of the evidence is expert opinion. So sometimes there may not be a randomized control trial. Sometimes it may not be appropriate to run a randomized control trial. But as you go up, you're trying to eliminate that bias. But in the middle is where randomized control trials are. And randomized control trials try to eliminate some of that bias of allocation, of choosing and picking who gets in a trial and who doesn't, that it's a randomized trial. And so that eliminates a big portion of some of the biases. Now, I should say when I use the term bias, I'm talking about something that systematically moves us away from the truth, not noise in the system. It's something that systematically pushes us off what the true goal is or the true effect size. And then at the top, well, considered the top, is a systematic review, and sometimes it can be meta-analyzed, so a systematic review and meta-analysis. That's considered the peak. However, you need to look at the details, because I would take a well-done randomized control trial over a poorly done systematic review, or a systematic review that only includes things like observational studies instead of a randomized control trial. There is one higher level of evidence beyond a systematic review, and all meta-analyses are systematic reviews, but not all systematic reviews can be meta-analyzed because the data may be too different or too much heterogeneity. But the one thing higher is a double-blinded, placebo-controlled trial that's a crossover trial with an N of 1. Because again, if you have a study, it usually involves a population. And we're not concerned about a population typically. We're concerned about, will this intervention work in this patient that I have in front of me? So an N of 1. But obviously that's not practical, so we do research studies that help inform our care for that N of 1. All right, so systematic reviews and sometimes meta-analyses, that is put at the top of that evidence hierarchy, but we have to watch out for something called GIGO. And GIGO stands for garbage in, garbage out. It means if you have a bunch of crappy little studies, CLSs, mash them all up into a meat grinder and spit out a point estimate down to the 5th decimal point. And this gives some kind of impressive p-value of less than 0.000001. It gives an illusion of certainty when certainty does not exist. If you're including crappy little studies, studies that are flawed, studies that have biases, studies that are observational studies and not randomized control trials. So you have to look at the ingredients. And that reminds me, I want to use the analogy of an apple pie. I grew up on an apple farm, and I don't care what you say, my mom makes the best apple pies. This is because she always used great ingredients, wonderful, crisp, tart apples, unrefined sugar, cinnamon, and all these other wonderful ingredients, and then bake them with love. But if you take all those wonderful apple pie ingredients and you add a cow pie. Now, I recognize that some of you people are from the city, obviously, and may not have a background in rural areas, but a cow pie, it's something that comes out of the back of a cow, and it lands on the ground and goes, and it's roughly the size of a pie. Now, if you take a cow pie and add it to an apple pie, all you get is a poop emoji. It doesn't make the apple pie taste any better. So that concept of what was included into the systematic review and meta-analysis is so very important. All right, so let's take a brief, and I mean brief, look at the history of evidence-based medicine. And I'm going to mention two things, early randomization trial and an early blinded trial. And so randomization is key to eliminating a lot of biases. And then blinding, certainly the patients, to which group they were allocated to, whether it was the intervention group or the control group, again, is very important. So I'm going to take a look at one of the earliest randomized control trials I could find and one of the earliest blinded trials I could find. So here's the first example. Before we had the germ theory of disease, it was accepted that there were 4 humors. There was the yellow bile, the black bile, the phlegm, and then the blood. And if one of those 4 humors were off, then you were considered to be in bad humor. And that's where we get the term, I hope you're in good humor. Oh, they're in bad humor. It's because of this prior to germ theory of disease being generally accepted, we had this theory about the humors. And so if one of the humors was off, right, that was the cause of disease and illness. And one of the most common treatments was bloodletting. And bloodletting was often done by barbers. And the reason barbers did it is because it was physicians and surgeons, and the surgeons were barbers. And what they would do is if you had a fever, they would release one of the evil humors, the blood. And they would release the blood and get rid of that blood to try to balance out the humors and make you feel better. And that's why barbers have poles that have these red and white poles, because they would lance you in the antecubital fossa, and then that blood would run down the arm as they drain the blood, and they would put a bandage on it, and it would create this sort of circular descending pattern. And so barbers would put that out in front of their stores to advertise that they bloodlet. Well, there was a famous Scottish physician. His name's Alexander Hamilton. Now, it's not the Alexander Hamilton of the Broadway musical. This is another Alexander Hamilton. And Alexander Hamilton, at the time he was a medical student in Scotland, was serving in the military. And he was skeptical about this community standard, the standard of care, to do bloodletting for fever. And so he was in the Peninsula War in Portugal back over 200 years ago. It was 1809. I know that was before any of us were born. So 200 years ago, camp fever was a common problem among soldiers. They would come in with terrible wounds or other infections, and they would be bloodlet. And he was like, I'm not so sure about this. And so what he did was he set up a randomized control trial. So they randomized 2-to-1. 2 people got standard care. So that when soldiers would come in, just as they would come in, the first 2, 1, 2, they would get bloodlet. That was the standard of care. And then the third person, so in a 2-to-1 ratio, that person, the lance, would not touch them. No bloodletting would take place. And then they had an outcome of mortality. So this was his dissertation that was published, and this is why we know about this. And so I will put up the 2x2 table here to show you alive or dead, so very patient-oriented and not very subjective. It's not like The Princess Bride where they're only mostly dead. This is alive or dead, and bloodletting or no bloodletting. And the no bloodletting was showed a mortality of 2.5%, so almost 3% if you didn't get bloodlet. So that 2-to-1 ratio, it was 2 people didn't get bloodletting and 1 person did, the standard care. So that 1 person who did get bloodlet, 28.7, almost 30% died, mortality, with the treatment, with the standard of care. Wow. And so you can calculate a number needed to treat, in this case, a number needed to treat to harm. So the number needed to treat was about 27%. So 1 in 4. The number needed to treat was 4. So out of every 4 people, right, number needed to treat to kill 1 was 4. And clearly that's bad. Now this is why randomization was so important, because up until this point they had observational studies. And observational studies, you could rationalize why the patient died, right? You could say, well, we didn't bleed them soon enough. If we had only got them to them sooner, we didn't bleed them long enough in the disease process. We didn't take enough blood off. We didn't take the blood out of the dominant arm. So all this hand waving to explain it in an observational study about why a patient would die. And until a randomized control trial was done, and it was 2-to-1 where 2 got bloodlet and 1 got no bloodlet, 2 got no bloodletting and 1 got bloodletting. Anyways, in that randomized fashion, only once you randomize patients were you able to find that answer, that actually bloodletting was more harmful, even though it was the standard of care. And standard of care means that's what people are doing. It doesn't mean it's the right care. All right, one other historical thing I wanted to go through, and that is a famous German physician, Dr. Franz Mesmer. Now, he believed in animal magnetism and that magnets could cure disease and illness. Okay, so before we had the evil humors, we think magnets were just being discovered, and he felt that magnets could treat a whole host of disease and illness. And he became very popular, moved from Germany to France. And he became so popular, he had to do group sessions. And these group sessions were called banquets, and they would have a bowl in the middle, and they would have these magnets, and people would hold on to these rods that would be connected to the bowl with wires. And then Dr. Mesmer would do his routine, and people said it would be very powerful for subjective things like pain, headache, arthritis, those types of things. Marie Antoinette became a patron of his and started spending a lot of money and time with Dr. Mesmer. This did not impress King Louis XVI and was not happy with all this time and money Marie Antoinette was spending with Mesmer. So he created a royal commission to investigate, is there anything to this magnetic treatment? So he got one of the most famous scientists in the world, and I'm sure you recognize this individual. This is Benjamin Franklin, and he was part of this commission put together. So he steamed over to France, and they did some experiments using Dr. Mesmer's technique. But what they did was they blindfolded the patient. They literally put a blindfold over the eyes of the patient so that the participant, the test subject, couldn't know whether or not the magnets were present or not present. And then they looked at the outcome. And for the outcome, this is what they found. No difference. There was no difference whether the magnets were present or not. And so the conclusion from this commission was that there was really nothing to this treatment. In other words, the patients were just being, and I know this is why you know this person, they were just being mesmerized, right? So they were being mesmerized by Dr. Mesmer, and it was a placebo effect for subjective outcomes. And this is where we get the term blinding. So a single blinded study was due to blindfolding of the participant. A double-blinded study is where the clinician, the treating individual, and the person receiving the treatment are both blinded to group allocation. And then a triple-blinded study is where the outcome assessor is also blinded to group allocation. So this is where we get the term a blinded trial. Because of blindfolds, because of Benjamin Franklin, and because of Dr. Mesmer, who was mesmerizing people. All right, now, of course, this is 2010. We're way too smart to be mesmerized, right? Living in the 21st century, having modern medicine and science. And yet, despite this, people are still fooled. And this can be beautifully illustrated by the story about power balance. Now, you may not know this story because some of the residents are younger, but your faculty or attending probably remember this. Now, if you're a little older, you'll remember those copper bracelets people used to wear on their wrist. You'd see them in golf courses and stuff saying, oh, it helps with my arthritis. It's copper. It'll help with my golf swing, those types of things. Now, copper became very expensive. However, silicone rubber bands are really cheap. And this company put a hologram picture on a silicone band. And they made claims that it would improve your balance, your strength, your athletic performance. That's why they were called Power Balance. And big-time sports stars and movie stars wore them and endorsed them. And there be the magic. But a skeptical group out of Australia sued the company and won because Power Balance had made medical claims, so they needed to demonstrate it. And because they couldn't, Power Balance had to remove the healthcare claims and offer refunds to people because it was a placebo effect. Now, the placebo effect is real and it is powerful for subjective findings, but we need to do blinded trials to try to eliminate that. Or we could easily fool ourselves like they did 200 years ago and like they did about 10 years ago. And so this is one of my favorite Richard Feynman quotes. And the first principle is that you must not fool yourself, and yet you're the easiest person to fool. And so I'm not better than anybody else when it comes to this stuff with regards to biases. I'm probably got just as many biases as everybody else. What we need to do is try to minimize and eliminate as many biases as possible. And we can do that with blinding and randomization. So those are key components to look for in any research study. All right, so that's the power balance story. Now let's talk about 5 alternatives to evidence-based medicine. So this was proposed by Isaac and Fitzgerald back in the BMJ in 1999, and they came up with a number of other types of medicine. So I'm advocating for evidence-based medicine, but what about other forms of EBM? And this is eminence-based medicine. So eminence-based medicine is you have that more senior colleague who feels that, it's less important to need things like evidence. I mean, experience can trump any amount of evidence. And these colleagues often have a faith in clinical experience, which is defined as, quote, making the same mistakes with increasing confidence over an impressive number of years. Now, the eminent physician will have that white hair, maybe a little balding patch, and they call that the halo effect, eminence-based medicine. And we've all experienced this. Well, that's how I've always done it, or that's how we've always done it here. Now, here's another type of medicine, VBM, or veminance-based medicine. And in veminance-based medicine, you substitute volume of evidence as an effective technique to browbeat your colleagues and for convincing your friends and relatives of your impressive medical ability. And what really matters is not the amount of evidence, not the volume of evidence, it's the quality of evidence that really matters, not how much the volume and how much they advocate for it that way. Now, of course, a third type is of EBM. This is eloquence-based medicine. And we've all met physicians like this. This physician has the year-round suntan from frequent trips by Big Pharma to Hawaii, a carnation in the buttonhole, silk tie, Armani suit, and that tongue that is just as smooth as silk, right? And that's eloquence-based medicine. What we should do is practice based on the evidence that informs our care, not how great the speaker is or how great the physician is advocating for it. Now, there is nervous-based medicine, that's NBM, and this is the fear of litigation, and that is a powerful stimulus in some environments to lead to over-investigation and over-treatment. I mean, in an atmosphere where it's a very litigious environment and there's lots of litigation phobia, what's the only bad test? Is the one that you didn't order. And so, of course, nervous-based medicine leads to over-testing and over-treatment. And then finally, CBM. And CBM is not competence-based medicine. It stands for confidence-based medicine. But this is generally restricted just to the surgical specialties. So, to summarize, this is how I feel about evidence-based medicine. It is the worst form of medicine except all the others that have been tried. Do we really want to go back to non-randomized trials where we're bloodletting people to try to remove evil humors, or doing unblinded or non-blinded trials or observational studies to inform our clinical practice? So, evidence-based medicine is the worst form of medicine except all the others that have been tried. I did say that I was going to give you some practical stuff. And so here's the practical component. These are the 5 easy steps, again, 5, my favorite number, that we'll go through to do critical appraisal. And the first step in doing a critical appraisal is to have a PICO. This forms your question and helps you narrow down with precision what you're asking. And then the second step that you have is to search for the evidence. And you need to develop a robust way to search the evidence quickly and accurately. So some of the resources that can really help you. And step 3 is to find the least biased. And again, the least biased means something that systematically removes you away from the truth. And so there's that evidence-based medicine hierarchy for the literature, for the quality of the literature. But then you need to critically appraise the literature to check. You try to find the best literature you can, and then you actually need to do a quality checklist to probe the literature for its validity. And then in the end, step 5 is to decide, is this practice changing? Is it practice affirming? Will it change my practice? Or is it meh, it doesn't really matter. But once you've done that 5-step approach, then you can approach the patient and make shared decisions. Because like I said, you're an expert at the medicine, the literature's informing your care, but you need to actually ask the patient what they care about, what their values and preferences are. So that first part is the PICO, that's the population intervention control or comparison and outcome. That is the PICO. And so when it comes to the population, you're looking at which group are you concerned about? And I think it's helpful to use an example. So let's say you have a woman with postpartum hemorrhage, a 32-year-old woman with postpartum hemorrhage. Your specific question is, what's the best treatment for that woman? Or will TXA provide a patient-oriented outcome benefit? What is the potential patient-oriented outcome benefit, a POO, with a TXA for postpartum hemorrhage? So evaluating a specific paper, you want to see that the study population included women who were pregnant who had postpartum hemorrhage. And you'll be surprised when you see some of these studies that are done. They don't include the population of interest. The worst example I've seen of this, or the best example, depending how you look at it, was a study that was looking at some associations with uterine cancer. You know who they excluded in that study? Women. All they included was men in a study looking at the association between certain factors and uterine cancer. And yet women were excluded from the study. Crazy. All right, so then the next step is, what is the intervention? This is part of step 1, doing your PICO. So we talked about the population. This is the intervention. What was the intervention? In this case, a treatment, TXA. And hopefully you can find a double-blinded placebo-controlled trial, or if there's enough of them, a systematic review that have similar primary outcomes that you can do a meta-analysis. And then you've got to say, were both groups treated equally except for the specific intervention? And in the example I'm using, it's postpartum hemorrhage and TXA to prevent mortality. That's very patient-oriented. All right, and so what was the control? That's the C of the PICO. What was the control? What did they compare it to? Was it controlled to a placebo? Was it compared to active control? In surgical trials, you're looking at sham surgeries or sham procedures. So you'll see this with angina studies where you're looking at stenting and stuff like that. There was a famous study from the 1950s where people had angina and they did surgery to tie off one of the mammary arteries, and they did sham surgery instead, but they both had an external surgical scar there, and to look at the outcome, that was the sham group. You've seen this in the orthopedic studies where they do sham arthroscopy, and trials involving acupuncture where they'll have sham acupuncture. So what did they control? What was the control group? What did they compare it to? It's very important. And was it a placebo or not? And then, of course, the outcome. And in this case, postpartum hemorrhage, was it a disease-oriented outcome? Was there less blood on the floor estimated by the MD? It's like looking down and going, I don't know, that's about, what do you say, 400 mils? I don't know, 500 mils? So is it a disease-oriented outcome? Do we really care if there's a statistical difference between 400 and 500, depending on how powered the study is with patients? What we care about and what patients care about is patient-oriented outcomes, not doo-doos, poo-poo, patient-oriented outcome. And so in the woman's trial, and the woman's trial was the large trial that was published recently about using TXA in postpartum hemorrhage. And the trial showed a mortality decrease due to hysterectomy. But the all-cause mortality was no different. And so from a patient's perspective, or in this case, the patient's dead, their spouse, their partner, their family, I don't think it's a big win to come to them and say, hey, I've got good news and bad news. The good news is they didn't die of postpartum hemorrhage. The bad news is they still died, despite TXA. And so if there's no difference in all-cause mortality, not just disease-specific mortality. And that was just an example. All right, this is step 2 of the 5-step process for doing critical appraisal. You need to have a search strategy. How are you going to find the literature, and how are you going to find it quickly and effectively? So you can do the one side here, which is Dr. Google. You can Google it. You can go to Google Scholar, which is a little bit better. You can go to PubMed, but that can be overwhelming. PubMed has a lot of citations. There are lots of other search strategies, and you might have some individual search strategies that work really well for you that give you high yield. Here are just 3 examples of search strategies that you may not know about that could be added to your search strategies. One is something called TRIP database. TRIP database stands for Turning Research into Practice. And I really like TRIP database. You go there, you put in your query, and you can search, but it only does higher level stuff, anything above a randomized control trial. So you're talking about systematic reviews, guidelines, consensus stuff, not observational studies and things like that in the lower part of that evidence hierarchy. You can also restrict it to, I just want to search guidelines. I just want to search systematic reviews. You can also restrict it to country. So you can say, listen, I'm interested in what are the guidelines in England, in the UK. They're called the NICE guidelines, or in Canada or in the US. So you can put country-specific stuff in there too. Then there's the Cochrane database of systematic reviews and meta-analyses, and they have a database that you can search. And then finally, there's something called clinicaltrials.gov. And clinicaltrials.gov, major trials now, if you want to be published in a high-impact journal, or a lot of the journals now, is that you have to register your trial in advance and say what you're going to do. So you can search this and find out, is there something that could answer that question? Has it been done? Has it been published? But even better, sometimes they aren't published because there is something called publication bias, where positive studies get published, but negative studies are less likely to get published. And so I went to clinicaltrials.gov recently when I reviewed last fall the TXA paper for traumatic head injuries. That was CRASH 3. And when I was going back and looking up TXA and intracranial hemorrhage due to trauma, trying to find out what the primary and secondary outcome for CRASH 3 originally were, I found out that there was actually a study done on TXA in the pre-hospital setting for intracranial hemorrhage that were from trauma. It hadn't been published yet. It's published now, and I'm going to be covering it on the SGEM very soon. But the data was there. You could review the results. I don't want to spoil it for you. You'll have to listen, but be skeptical. All right, then the next step in this 5-step process is you have to find the least biased and highest form of evidence. So you you do your search, you find it, and you want to find, okay, was this an opinion piece? Was this observational studies? Was it case control trials? Was it some cohort which lacked blinding? You get up to randomized control trials and then up to systematic reviews. So you would want to find not that lowest form of evidence, that guy down, me, on the bottom, that's why I said guy, that person down on the bottom giving their opinion, or do you want to find a much less bias or higher quality of evidence? And I'm holding up the Cochrane review as a very high standard. And then step 4 is to critically appraise it. And that is a process all on its own, but there are various checklists available online that you can do. And how do you get good at critically appraising a paper? Practice, practice, practice. For randomized control trials, there's 11 questions that you ask of the paper. And so I just go to the methods. That's the first section I read after the headline. I read the title, and then I go to the methods section. And for randomized control trials, there's 11 quality checklists. And I know most of them in my head because I've been doing it for so long. But you go, okay, was this randomized? Were the patients blinded to allocation? Were they treated equally except for the treatment? Were both groups similar at baseline? What was the outcome? Was it patient-oriented outcome? What was the heterogeneity? All sorts of things go into this quality checklist. And you go check, 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 check. And you get pretty good at it. And you say yes, no, or I'm unsure. And there are sites on the web that you can go, and I've put up the Center for Evidence-Based Medicine there, and they've got all these checklists for randomized control trials, observational studies, systematic reviews, clinical decision instruments, diagnostic, therapeutics, those types of things. And then step 5, the last step, is this practice changing? You've got to look at the evidence and at the end go, okay, I've asked a question. I've looked up for the evidence. I found the evidence. I found the best evidence. I've critically appraised this evidence, and it'll have limitations and problems. And, you have a patient in front of you. Now you have to make a decision. And will this change your practice? Will it reinforce your practice? Or will it be, it doesn't do anything, doesn't move the needle? What's the number needed to treat? What's the number needed to harm is another way you can express it. But that's the 5-step process. And I'll just remind everybody that the burden of proof is on those making a claim. And so those usually publishing a study are trying to make a claim, and the burden is on them to prove their claim. And we accept a claim, and it's usually a claim of superiority, like treatment X has this patient-oriented benefit, a POO. And if the burden is met, we go, I accept the claim. This is something I can incorporate into my practice. If the burden of proof is not met, then we accept the null hypothesis in science. And the null hypothesis just says that it's not superior. Now, accepting the null is not the same as claiming a treatment doesn't work. That would be asserting a claim. So accepting a null, this is an important point, accepting the null is not the same as claiming a treatment does not work. All it means is we're not convinced that it does work. And we're not making a claim that the treatment doesn't work. And this is an important distinction in epistemology. And it's called a burden for a reason. Not because it's easy, but because it's hard to prove something. But the person making the claim, or the individuals making the claim, assume the burden of proof. All right, well, we're getting closer to the end, and here is some arguments against evidence-based medicine. As you can tell, I'm an evidence-based medicine enthusiast, but you've got to look at what are the flaws, what are the weaknesses, what are the criticisms of evidence-based medicine. These aren't all of them, but these are some of the big ones. One of them involves harm, and it's typically brought out the parachute trial. Most research findings are false. Nope, that's not true. How about, I'm just so busy. Are you serious? How am I possibly going to search the literature, do shared decision-making, read all the guidelines? And speaking of guidelines, I read them, and most of the guidelines are crap or weak or have weak evidence. And then finally, even if we have good evidence, I'm not going to listen to it. So, one of the first arguments against EBM is about parachutes. So I want to clear this up. It's obvious you can't do a randomized control trial and put a patient in potential harm's way if you know that it would harm them. And the classic example is Smith and Pell's BMJ article from 2003 about parachute use to prevent death and major trauma related to gravitational challenges. And it was a systematic review of randomized control trials. Parachutes have been used for years to prevent orthopedic injuries, head and soft tissue injuries, and other gravitational challenges from jumping out of a plane, including death. Now, there was observational data showing that parachutes, even when used properly, people still get injured. They still die when they jump out of a plane and the parachute opens. But there are also case reports of the parachute not working and people surviving a free fall. And so these authors, Smith and Pell, with their tongue firmly placed in their cheek, said, well, there's no randomized control trials on this. So we don't have definitive evidence of whether or not a parachute would prevent gravitational injuries. And so they proposed taking evidence-based medicine proponents like myself, and this was to point out dogma, take us up in a randomized, double-blinded, placebo-controlled trial where half the participants would be randomized into a backpack and half the patients would be randomized into getting the parachute, the intervention. So the sham, the control, the comparator, was a backpack that would look like a parachute, but when you pulled the ripcord, nothing happened. Now, to make it more rigorous, they said, well, all go up, everybody jumps, and those who survive, regardless of whether they're in the parachute or the backpack group, it would be a crossover trial. And then they would go up again and they'd be randomized, or they would be put into the other group and then jump again. And then we would have really, really robust evidence. And this was to point out how absolutely silly it would be to do a study like that. However, most medical treatments are not parachutes. I mean, gravity is a very, very well described thing. We understand gravity very well and the force involved. But most medical procedures are a lot less clear, and they're not parachutes. And so Hayes et al. Discussed this in the Canadian Medical Association Journal back in 2018. Most medical practices can be actually tested and are not parachutes. And in fact, there has been a randomized control trial on parachutes. And this was done by Ye et al. In the BMJ, published December 2018. Yes, there is a parachute trial. So they had 92 passengers age 18 and older who were screened for this, and that's important. So they screened those passengers. They approached them in the airplane. Now, 23 people agreed to participate. They were given the information and they agreed to be randomized. The intervention was a parachute, and the control group was a backpack. And the outcome was a composite outcome of death or major traumatic injury. And so that's the PICO. The population was adults jumping out of a plane, a parachute or a backpack, and death or major traumatic injury. The results of these 23 people, the parachute did not reduce death or major injury. There was no superiority found. It was 0% versus 0% with a p-value of greater than 0.9. And I'm sure you're wondering, well, how did that happen? Well, there was a difference between those who agreed to participate and non-participants. Participants jumped from an average height of 0.6 meters or 2 feet. And we're traveling in a plane that was going, I'll translate, it was going 0 kilometers an hour, but I understand this is a US, so 0 miles an hour for the US audience. Now, while non-participants, those who decided not to jump out of the plane, they were traveling at 9,000 meters, or roughly, well, that's 9 kilometers, or almost 6 miles up in the air, and traveling at over 500 miles an hour. So you can see why nobody got injured when the plane was on the ground and not moving, and those people jumped with or without a parachute. All right, another argument against evidence-based medicine, and this was published in 2005 by Ioannidis, and he published a study called Why Most Published Research Findings Are False. And this is one of the most cited papers ever, and he's one of the most famous scientists in the literature currently. He's the co-director of something called the Meta Research Innovation Center at Stanford. Now, he has gotten into a little difficulty recently with the COVID stuff. I'm not going to go into that now, but this is a great paper. Again, it's one of my favorite papers, and I suggest you go back and read it, because most published research findings are false. And this is because they're asking the wrong questions, they're using the wrong methodology to answer those questions, the results that they're getting are being misinterpreted, or the statistical analysis is not correct, or they're overinterpreting the outcomes. These and other issues are why he felt that most published research findings are false. So why do evidence-based medicine? Another argument against evidence-based medicine is, it's all cookbook medicine, right? But that is a focus just on the literature. And remember, evidence-based medicine is more than just the literature. It's not following a cookbook. It's not following a recipe. The great chefs of this world don't just follow the recipe, they also still use their judgment. The great physicians of this world, right, follow a recipe. They can look at the guidelines, but the guidelines inform our care. The literature informs our care. It doesn't dictate our care, and you still need to use your clinical judgment. And you also need to ask the patients about their values and preferences. So yes, you can make the argument that evidence-based medicine, if you just follow the literature like a cookbook, yeah, sure, but that's not what evidence-based medicine is. So that would be a straw man fallacy. All right, and one more argument here is about the guidelines, and that most guidelines are poor, at least the evidence contained in those guidelines. And here are two citations. One's from 2009 and one's from 10 years later, 2019, both in JAMA. The first one looked at about 53 guidelines, I think, 53 guidelines with over 7,000 recommendations. And they looked at the level of the recommendations, whether they were level A, which means we've got a lot of robust evidence to include. Level B is like, we got some evidence, maybe one randomized control trial, some observational studies. And then level C, which was very weak evidence, consensus statements and things like that. And when you looked at those 7,000 plus recommendations, 50% were level C and just over 10% were level A. So most of the evidence was poor. Jump forward 10 years ago, 26 guidelines in the AHA and ACC with almost 3,000 recommendations. Even less were level A 10 years later. 9% were level A, that you've got really good information to inform our care. 41% were level C. And then finally, even when we have good evidence, we tend to ignore it. And I like to use antibiotics as an example. And if you look at what is the most frequent reason antibiotics are prescribed in children, it's acute otitis media. And yet we know that acute otitis media in an otherwise healthy child over the age of 2, 85% will spontaneously resolve their otitis media within 2 days. And yet it's the number one reason we prescribe it. And we've got lots and lots and lots and lots and lots and lots of data on that. And yet it's still ignored. And then in the adult situation, it's bronchitis. We know about 90% of bronchitis is caused by viruses. Antibiotics don't work on viruses. And yet it's the number one reason adults get antibiotic prescriptions is for bronchitis, when we know most of the time, 90% of the time, it's a virus. And even in the 10% that it's bacteria, we don't know if it's a right match and how big of a patient-oriented impact it'll have. Will it shorten the illness that's usually, a couple of weeks, 1 to 2 weeks, by a few hours or a day or two? So the number one reason we prescribe antibiotics in both children and adults, we've got good evidence, and yet it's ignored. One more, and that is the lack of time. And this is about shared decision making and the lack of time. The argument is, that's not realistic. I don't have time. Like, look at the faces in these people. We're running a code. We've got a critically ill patient, and they're like, yeah, seriously? You want me to go look this up? You want me to do a search for the best evidence and critically appraise it and then try to talk to the patient? And what about the patient's level of health literacy and communication barrier? And I'm juggling 5 things and I haven't peed in 8 hours and I haven't anything to eat, right? So how do you have time to do evidence-based medicine and do that shared decision-making where you know the literature, you're using your clinical judgment, and you're engaging the patient? I can tell you though, if you do it and you practice, because it's the practice of medicine, you can get better at it, you can get quicker at it, and when you get quicker at it, when you do shared decision making, it doesn't take more time, and it's a much richer clinical experience with higher patient satisfaction. And again, this is how I feel about evidence-based medicine. It's the worst form of medicine, except all others that have been tried. I personally do not want to go back to bloodletting, non-randomized, non-blinded trials. So let's bring this back to something very clinically relevant and current, and that's COVID-19. COVID-19 has tested our ability to be rational and use science to guide our care, and we need evidence-based medicine more than ever. And this was seen because COVID-19 unfolded like a dumpster fire. I mean, look at the masking messaging, the mixed messages on masking. Look at the physical distancing, was told to be social distancing. We need to stay socially connected. I'm connecting with you guys today socially, but we're staying physically distant. How about the hydroxychloroquine study? All those observational studies and preprints and stuff like that, people jumping on board and jumping on the hydroxychloroquine train. And really, should we have? Because we needed better evidence from randomized control trials. And when that stuff came out, it was like, yeah, no. And then remdesivir, we were practicing by press release. Convalescent plasma, getting an emergency authorization use on an observational study that hadn't been published yet. Now it's in preprint. And then it was miscommunicated by association is not causation, because the use of convalescent plasma, we can't claim that it causes decreased mortality, only that it was associated with decreased mortality because it was an observational study. And then mixing up relative reductions versus absolute reductions. Yeah, there may have been a 35% associated reduction in mortality in a subgroup, but the absolute risk reduction was only 4%. Now, 4% is a big deal in mortality, but mixing up relative versus absolute reduction, I mean, that wasn't good. And then, next up is vaccines. We need to get this right. And I think to date, it's been a bit of a dumpster fire. So Simon Carley, who's a friend of mine, works with the knowledge translation project called St. Emlyn's, excellent site. He published an article with some of his colleagues in the British medical journal Evidence-Based Medicine and spoke to the urgency of COVID-19, that it represents both a threat and an opportunity for evidence-based medicine. And I agree with Simon. They go on to state that evidence-based medicine is more important than ever, and that all of us must try to use science and not let our emotions, and that's very difficult because, we have family who are put in harm's way. Maybe you've had family members that have become sick, all of that stuff. We've got to use science and not let our emotions get in the way. Politics or economic issues interfere with the science. And they encourage at the end to use critical reasoning, and that we should be using critical appraisal and our critical thinking skills during COVID-19. I would say we should be using it through COVID-19 and beyond. And so that's it, just the final take-home message, but I told you that at the beginning. So let's see if we can remember it. The first thing was evidence-based medicine. It rocks. And the second thing was, and we may do this with the question and answer period, the answer will be, it all depends. And finally, be skeptical of everything, including what I discussed today. Go back, read the primary literature, think about this for yourself, and decide if this is something that you can incorporate more into your practice. Thank you very much.